Hi everyone. So I work in the emergency center. So the reason I am here is because I have to deal with this very often. And unfortunately, a lot of times I get given a patient with no history, nothing, we don't know what's going on, they're just not well. And we have to kind of respond to that. So today we're looking at a whole lot of things. We've been given a lot of very, very good terms, a lot of very fancy stuff, which is brilliant and so very important. I'm just going to take it down to more the basic picture of what we're trying to do and kind of get something into our heads to go, how do we approach this practically when this patient is in front of us? Okay, so to begin, I was in the emergency center. It was about 4 months ago. Got a phone call to say the ambulance is wanting to come in. They've gone to someone's house. She was about, they said about in her 70s, 80s, and she was cold, she was clammy, her SATs were 40%, her blood pressure was unrecordable, and her heart rate was 30, but it was going quite fast is all they could say. And they were saying they couldn't get a line in. They're like, we need to give her some fluid, we can't get a line in, what are we going to do? She's going to arrest, we need to give her some fluid. So I said, okay, well, bring her in and let's see what we can do. So they rushed her in, she arrived on the bed, she was this tiny lady, little thing, put her on the bed, cold, clammy, put on the SATs probe, SATs were sitting at 60%, we couldn't get a blood pressure reading, she still had a pulse, so she hadn't arrested. Now what? What are we going to do? What does everyone want to do? We want to get lines in, we want to give them some fluid, because that blood pressure is low. Okay, but what's happening? This is where it's important to understand what is shock and what is going on with it, because that decides everything, how we're going to approach it. Now, we're going to cover between an inotrope and a volume expander, but we need to know what we're dealing with. So, what is shock? A whole lot of terms. We've gone through a whole lot of them. It's the many ways we can talk about it. Most people practically think it just means low blood pressure, is what everyone kind of thinks it actually means, okay? But what does it really mean is there's some failure, and it's circulatory. The body is not working the way it's supposed to be, particularly when it comes to the circulatory system. It's going to cause cellular and tissue hypoxia. So the tissues are struggling. They're not getting what they're supposed to be getting. Now, a lot of times, again, this must be blood, there must be volume, there must be something. Why are they not getting what they're supposed to be getting? And it is life-threatening. Okay. Now, the exciting part is, unfortunately, sometimes us healthcare professionals are the ones who are life-threatening. We put them in this state. Sometimes we take them from this and do the wrong thing. And that's what we're going to look at a bit now. Okay, so she was put on the bed and we were going to start. Now, types of shock. We've all seen this list. We all kind of know it. We're going to kind of go through a bit more detail, but basically hypovolemic, cardiogenic, distributive, and obstructive. These are great terms. I think we all understand them. But let's keep it really practical, kind of dumb it down for us emergency guys. You know, we've got to keep it simple. We're going to talk from our level and give you guys a nice little picture of what we're dealing with. So, basic system, you've got a pump, you've got some pipes, and you're trying to water a plant at the end of your garden. Okay, if I don't get water to those plants in the end of my garden, they're going to die and it's going to do badly. So I've got to make sure that I get water there. Now, what happens if I'm not getting water there? What could it be? A couple things. What are we looking at when it comes to hypovolemic? Very simply, there just isn't enough volume. There isn't the water. That's what's missing. What could be causing it? There could be hemorrhagic. Sometimes it's obvious. The guy comes in, car crash, they're bleeding, blood's pouring. Sometimes it's a car crash and you can't see them bleeding, but they are. There might be something else going on. It might be GI losses. The guy could come in, severely dehydrated. There could be a lot of different things that could be causing it. You may not be able to see it. A burn patient, a severe allergic reaction, toxic epidermal necrolysis, kind of skin losses. Third space, that's your pancreatitis. These are the kind of patients that are losing fluid somewhere, but you may not even see it. So basically, okay, what do they need? Well, probably need to give them some volume. Okay, that kind of makes sense. That seems okay so far. What about cardiogenic? Here, what's happening is the pump's not working. So I'm at the end of the garden, I want water to come out, it's not coming. Do I need more water? No, the pump's not working. I need to fix the pump. Now why would the pump not be working? Maybe the pump is old and it's damaged. It's cardiomyopathy. The patient's had multiple heart attacks. That heart, instead of being this nice strong pump, is this thin very weak thing that's struggling to do anything right now. And something has made it a bit worse. But the problem is the pump. And there could be arrhythmias, the pump's rhythm's out, it's just not working, the gears are off, there's something there, it's causing it. The end result is I can't water my plant though. So I can see it, but how do I fix it? Do I put more water in? That's not going to fix the problem. That's not where the problem is. It's the pump. We need to help the pump out. Okay. Distributive. Now, this is a big one we're looking at here, and everyone's going to be covering it, but what is that? This is now, I've got the same, I've got a pump that works. Okay, I've got the water, I've got the volume. I have a nice little thin pipe. Okay, that's working fine. What if someone gave me a massive pipe? Just this big pipe that could just allow for this water to go everywhere. The water's not going to come out with any kind of pressure at the end. What if that hose pipe, well, I don't realize that someone's gone along it and just been punched a whole lot of holes into it, and the water's just, instead of just coming down one stream right to that one plant I want to do, it's kind of spreading everywhere out there into the grass behind me and just going everywhere. That's distributive. Okay? What do I need to do here? Is the pump the problem? Do I need more water? What are we dealing with here? Okay. So it gives us that kind of a picture. Neurogenic, the vessels just go out really big. Suddenly, it's not that I've lost water. It's not that I don't have a working pump. It's just not getting where it's supposed to be getting. Obstructive. What about this one? So this is another tricky one. Basically, you've got this patient, you've got enough water, you've got a working pump, but something's stopping it from going. Maybe something is slowing down the pump. There's something in there that's jamming that pump up that won't let it move the way it's supposed to move. Maybe where it's trying to draw from is blocked and it cannot get it in. So water's trying to come from the borehole, it's trying to get into the pump and then get where it's supposed to go. It can't get in there. It's not working. Okay, so just to give us those pictures, we now know our different types of shock. That gives us a bit of a picture. Now, what do we do with them? What are we dealing with when we're actually looking at it? So, what is the most common? Because again, maybe we just start there. We'll just go for the most common one and see what we can do. It really depends on your setting. If I'm sitting in a trauma center, my most common one's probably going to be hypovolemic, much more than it's going to be this. Okay? In an ICU, a lot of times it's going to be more distributive, most commonly kind of sepsis. But it's not just one thing. So we can't go and say, well, this is how we treat things. And like we were saying earlier, we mentioned we've got so many monitors, we've got to piece together this and go, what are we dealing with right now? Because it can change. That trauma patient that came in who was hypovolemic has now got a tension pneumo because you've been ventilating them. Do we just keep on giving them volume, or do I look for what else is causing it? So we need to understand there's more to it than just giving them more volume or more blood. Now, how do we manage it? The key is recognizing it early. Now, we've covered a few things here to pick up, but people don't do this. Sometimes it's so obvious once someone's pointed out, other times we miss it. The key is we're looking for this in essence all the time. We have patients that come in, they're sick. There's something wrong with them. Any one of them could go towards shock. That could happen. So if I've got someone who comes in with a pneumonia, it could start from just a mild cough and they're fine and they're going to go home. Or it might become a bit worse and they're kind of struggling. Now they're a bit more sick. And the next second they've gone into shock. That's something I've got to look for. That could be that patient. I've got the patient coming with a chest pain. Suddenly it turns into a heart attack. Suddenly the system fails. It suddenly turns into this. So the point is with shock, you can see any patient can go in there. And it's something we're supposed to be asking. When we approach a patient, now it's obvious. The guy walks in and he's well. He's not in shock. We've cleared him. He's okay. But when you've got a sick patient, this is one of the things you're getting to. Okay, they're sick. Is this shock? And you want to know, how do we pick it up? So if I see that patient who comes in who's got an obvious urine infection or whatever it ends up being, is the body under strain? What am I picking up? And this thing about multi-organ failure, sometimes we think it's going to be just the blood pressure, it's just the heart rate. It's not that. People love to live. Blood pressures of 90 over 60, 80 over 40. That's some people's blood pressures. They're fine. They live at that space. You've got that end-stage kind of cancer patient. They're not in shock. Sometimes their blood pressure is just that. You don't want to give them a whole lot of volume and inotropes. They're still talking to you. They're putting out urine. Their organs are not taking any strain. You know, their UNEs aren't off. These are things that we're looking for. So the key is having this idea of looking for it and being aware and picking up those signs. Now, suddenly when I say to you, did you notice that pneumonia patient, his kidney function was a bit off? And you go, oh yeah, so he's got pneumonia and a bit of kidney impairment. No, he's got pneumonia, but why is his kidneys taking a bit of strain? Oh, they're not being supported. There's something going wrong here. They're not doing as well. Suddenly that becomes one of the indicators of this patient is going somewhere. They're getting worse. This is something I need to look at. I don't just break them up. I look for that. So the key is first, to recognize it. We miss it all the time. The patient that becomes septic, and the patient often decides that. I've seen people who should be in shock, just won't go there. Never will. Ask the ICU guys. Some guys come in, it doesn't matter what the infection is, their body will just never go there. They just don't want to do it. Some other people come in with the most minor insult and they go straight into shock. Their body just, huge reaction. So we're looking for it all the time. So looking for it, but don't miss the obvious stuff. Is everything working? What's taking strain? It's taking strain, call it that. The systems are taking strain. And we look for more systems that are taking strain. Okay, there's something going on here. Okay. We want to support the patient, and this is what we're going to look into this next little bit. How do we support them? So we're going to look into, obviously, there's the obvious stuff we know here we're not covering here, like if the guy needs to be intubated or ventilated. There's a lot to be said about that. But we're going to be looking into your inotropes and your volume expanders. But we've got to support the patient. Clearly, that's what they need. They're not just someone I go, okay, look, you've come in with pneumonia, you've got a bit of sepsis, here's some antibiotics, good, like I'll see you in the ward, I'll see you tomorrow. No, I need to support the systems. The system is taking strain. Okay. Then treat the cause. This is very, very important. We've got to look at treating causes. So this is what a lot of us are doing in many ways. You know, it's the same thing we take with someone in cardiac arrest when their heart stops. We're trying to find the cause. We can do CPR. We have to do CPR. We're straight on to CPR. But I can do CPR all day long. If I don't cause what made your heart stop, I'm kind of wasting my time. Okay, so these things have to happen, and it's such an aggressive look. We have to be doing it. What is the cause? Now, sepsis can look like antibiotics. So what does that mean? I've given the antibiotics early. I want to get the right antibiotic. I'm going to watch them so very closely. But I'm going to do a whole lot of support because it's going to take a time to work if it's something just a general infection. If it's something like an abscess or an appendix, I need to go take it out and do something about it. Other ones are a lot more quick. What if a guy's come with a heart attack? I've got to open up that vessel. I've got to go in there and I've got to open up that vessel while I support them. Okay, so understanding that this is what we're trying to do. We want to recognize it early, and that is every patient all the time. And someone presents a patient to me, especially ones we're going to see in the hospital, is how are they doing? Okay, this is what's wrong with them. Okay, are they taking strain? Okay, are we looking? Are they heading to a place where they need more support? We want to pick it up early because it can be reversible. Gets a bit late, very little that can be done. Okay, so how to manage shock? Let's keep it simple. Know all these other terms. This is what we want to do. We want to be able to look for it. We want to be able to treat a cause, and we want to be able to support it. Okay, so inotropes versus volume expanders. Okay, this is the big talk. Everyone's looking here because everyone goes to both. And what do we all think? We're all like, oh, we just give both if you don't know. Everyone kind of just jumps on it at some point. We just need one, we need the other. We give this one, we give that one. Often we're just thinking we're supporting shock because that's what we're trying to do. I want to just, this is how you treat shock. We've heard all the stuff. We've got to treat shock. So this is how you treat shock. Just give them both, right? Fortunately, not that simple. We've got to break it up a bit further. There is inotropes and vasopressors. If you really look, we all call it inotropes. Inotropes are particularly related to the heart, and what it does, it increases or decreases contractility. Vasopressors have got to do with the vessels. Okay, so first to start with this picture, what are we talking about? When we talk about these things, we've got to think about that system in that way. You've got a heart doing its job, and you've got the vessels doing their job. So when I'm talking about inotropes, I'm talking about inotropes and vasopressors. That's the I'm trying to support. Now, I can go both ways. What they're saying is that they have an impact on those systems. So they might make the heart beat more or beat less. They might make the vessel constrict or they might make it relax. But what these things do is they impact on those things. So kind of leaving it as just this open picture of I'm just starting an inotrope, you've got to realize we've unfortunately got to go a bit further and go, okay, which one and what are we doing with them? Because that's not just this blanket term that a lot of us use. Oh, just start it. Okay. So first to start there. How they act on different places. Here's just a couple of them. Again, I could bury you guys on a whole lot of terms. You guys have got most already there. But certain receptors do certain things. So if I do something that works on just an alpha-1, I get vasoconstriction. Okay? That sounds great. That means, doesn't vasoconstriction mean blood pressure is going to go up and my problem is blood pressure? My problem is not blood pressure. My problem is whatever's causing this issue with this patient. What if it's a weak heart? What if it's a heart that's just not strong and it's struggling? If I go and take this pump that is this old, rickety, really struggling pump, and then I take the tap that's coming out of it and I go, well, let me just kind of close the tap a bit further. So we're going to make it even tighter. Is that helping out that pump? No, it's terrible. This poor pump, which was the whole problem, they put them in the space, is now working harder. That's making it worse. Okay, so we've got to understand that these are the things we're doing. What if I just make that pump go like crazy? Let's just speed the pump up. That'll solve every problem. Let me go in there and like literally just put my foot on the gas, make that pump fly. The pump can't do it. It's an old rickety pump. If I push that pump too hard, that pump's going to fail. We know that. Okay? So we've got to realize when we're talking about these things, there's a bit more to it. We've got to understand we want to treat a thing. So we can't just say the patient is in shock. That's why I want to know the cause, and I know they're in trouble. Now I've got to decide how to support them. And this is when you start to play around with what are you doing and what have you got. Okay? So we've got that idea, and now we go a bit further. So we can go into that. Sorry, the slides aren't very clear. These are your vasopressors, and these are all the different things that they do, and we can go into it. And I'm actually fine that it's not clear because it's more important for us to get out of this talk what we're here to talk about. But you will see that these are the ones, the top there's phenylephrine, you've got vasopressor, you've got norepinephrine, and up here's your alpha-1, your betas, your dopamine. These are all the different effects that they have, okay? So I'm either going to be increasing or decreasing. Now there's some interesting ones that you'll see. You know, your vasopressin here doesn't do too much on your alpha, your betas and things like that, but it does affect systolic, your peripheral resistance. There's different ones that have some effect more one side, less the other side. Some are impacted by their dose. Now that can be tricky too. Okay, so when it comes to choosing what we're going to do, when I say inotropes or volume expanders, I've got to know it's not just this idea of, oh, it's just, am I giving one or the other? Well, which one am I giving? What am I going to do about it? So first, to give that idea that each of these things do different things and do things better and worse depending on how you give it. Okay, so that's the inotrope vasopressor side of things. So now how do we treat shock? So I told you before, we started with what we said, recognize early, we want to treat, we want to go there. Now what do I decide to give? Okay, so I've either got something that's going to make the pump work hard or close the tap, or I'm going to give a whole lot more volume. Okay, hypovolemic. What should we give? Blood. Everyone gets blood? We give volume, okay? But that is so very key. When a trauma patient comes in, I have yet to find a trauma patient who's died because they've lost too much ringers when they were shot. That's not why they're dying, okay? They lost volume, but they didn't die because they lost ringers, okay? They need blood. Okay, so it is exact. When we talk of volume expansion, it depends on what we're dealing with. So when we go here, when I ask you the question of which one are we going with, it's not about, oh, hang on, it's either this one or this one. It was which one. We spoke about which inotrope. But if I understand it, I've got something to deal with. Okay, so hypovolemic, it's probably volume. Sometimes it's 1 liter of fluid is all it took. That 1 liter of ringers, and that trauma patient was fine because they stopped bleeding. Hang on, that wasn't enough. They're not responding. Okay, I need to go more. Now I want to go on to blood, and then I go on to blood. If it was the GI loss patient, yeah, ringing sounds great. We'll go that way too. Okay, so one is looking at the cause, tells me which way to kind of go. Now, sometimes that's not enough, and then I'm going to go volume first, and I might still need to go on to an inotrope, but that's the way I'm looking at it. If I take the trauma patient who's bleeding, and I don't know where, and I'm just like, I want to get a blood pressure up to normal, because shock means normal blood pressure. That's not what it means. I need to know, is the organs okay? So if a trauma patient comes in and they're talking, and they're fine, I don't have to push them any higher because the shock wasn't about a blood pressure. It was, how are they doing? If their system starts to fail, I've got to do more. Okay, here's some volume. Here's some blood. Okay, we're cool. We can hold now. Hang on, the organ's taking strain again. The guy's GCS is dropping. They're looking worse. Okay, I need to go further. Sometimes I have to go even further, and then I start looking at inotrope in those patients. But it's understanding that's where we're going. Cardiogenic. That's that old pump. Okay. Do they need more volume? What if this old pump is sitting there? And remember that patient, what about a cardiogenic patient? Think about that cardiomyopathy. This guy's got this old rickety heart. What have they always got? Too much volume. That's what they actually have. They've come in, they're on diuretics all the time because they've got too much volume on them. Do I just give them a line and run in some fluid? No. I've just taken this poor pump that was doing this, and then everyone looks at how do we get through these parts and telling these things. So I'll put an ultrasound on and that kind of stuff. And then anytime someone brings out an ultrasound, everyone's like, oh, tell me the ejection fraction. Don't worry about that. Is it a good pump or a bad pump? That's what I need to know. What's a good pump look like? A good pump's doing this. Okay? A bad pump, doing that. Okay? What's a bad pump look like? So what does it actually look like? It's doing this. It is so stretched that it can barely do anything. If I gave them a bit more fluid, what's going to happen? They're out of luck. Okay. Now, these things we can tell. Ultrasound could do it. How about putting up an X-ray and going, hang on, that heart's a big heart. Now, even a weak heart, once their volume is down, it's still going to go to a small kind of size. It'll move, not very well, but it'll go there. But a weak heart blown up like a soccer ball on a chest X-ray, that heart's full. That's really full. It probably needs help. The pump needs help. They don't need more volume. Okay. Distributive. Now, this is where it gets a bit more tricky. Because a lot of times they've lost volume, that's gone into the tissue, you just don't see it. They didn't bleed, they're shocked. It goes into the edema, it goes everywhere else. So I got to give them some volume. At the same time, I can't keep doing that because after a while, I've got to remember this person is sick and septic. Their heart isn't actually working that well when they're very septic. They're acidotic. There's a few things that are a bit more complicated that we've got to be cautious with. And that's why we will have to balance both. And in the end, pay for both. If I give you a whole lot of volume now, that body is not going to get it out. If I can literally take, here's a sponge, like a person, and I just keep pushing water in, it's got to come out, and we know where it's coming out, but it's got to come out. If I keep doing it, this is where the ICU guys then pay for it for the next 3 weeks, trying to get it off, because suddenly it's got to go somewhere. Okay, so yes, they need it, but how much do they need? And this is what we're talking about, monitoring very closely and deciding which one. And that's why you'll do the balance. Okay, now I need some inotrope, because I can't just keep giving them fluid. And you will make the balance looking at what is this patient dealing with. Okay. So in many ways, it might sound like, hang on, before it was simpler just to know the one way. Now it can be simpler to go, hang on, I can think about this a little bit. And we can talk about it at the bed and go, hang on, there's something wrong here. Well, which one is it? Is it a bit of both? What could we go with? Let's try and see what we're going to go with. Because to check volume, unfortunately, there are entire conferences trying to work this out, and they don't get a final answer. The best way to tell if someone can have fluid is by giving them too much. And going, oh yeah, that was too much. That's what it looks like. 250, okay, I think they look better. Another 250 mils. Okay, cool, look at that. Another 250, well, went too far. That's actually the final answer. There's so many other ways we don't want to get there. So we've got to be cautious, but it's not always that simple because the patient changes. Okay, so surviving sepsis. Now, this is another thing I was given just to talk on, just to give us a quick idea of it. Now, we've spoken about other shocks, and I think a lot of times we go straight here is what we're talking about. You've heard me describe others now. When I run into a resus in ICU and all that kind of stuff, the first thing I go to, I don't go say, it must be sepsis. It could be 1,000 other things. The patient has a central line. Maybe they've got a tension pneumo. There's a ton of other things we're looking at. So that's one place we're looking. But imagine from my side, I've got a patient who comes in from the outside, just lies in the bed. Now what's wrong with him? Okay, surviving sepsis, just to give a quick background, people die from sepsis, and it was very high. The surviving sepsis guidelines came out. They gave a very clear look. And what they were really good at was going, let's diagnose it. How do we look for it? And they gave a very protocolized first, initially, this is what you have to do. Measure this, do this, measure this, do this. And they found better outcomes, which was fantastic. But they were very strict. They were like, everyone got this kind of a line. If this was low, everyone got blood. You can't always follow it. But they found an improvement. So that was important. Surviving sepsis means looking for sepsis, what I've spoken about now. Identify early, treat well. There was very much in the beginning, a lot of guys had the bundles and you had to do it. There have been more studies now that talk about early goal-directed therapy. And the idea is trying to support, like I've spoken to you now. Pick it up and then deciding how best to do this without just going too far. And done well, they respond very well. Okay, so that was surviving sepsis. So just to go on, now you've got, still continue, surviving sepsis is a fantastic organization. They're putting out new guidelines. So some people have kind of saved it back as rivers back in the time, like, oh, that's what it was an old, they're fantastic. They keep on putting, they keep on describing. It's like think of it kind of like your ACLS and your guidelines that are coming all the time. That's what they're doing, and they're showing that this is important and they're progressing. This changes all the time. You've got to keep up to date with it. Look it up. Put it in your phone. Surviving sepsis. Go in there. Look at your latest stuff. They will give you a lot of very good stuff. But the point they're focusing on, again, is surviving sepsis, not shock, sepsis, and they describe what we're doing. And a lot of what we're saying is this: treat, cause, know what we're giving. Then there's now, what is the best way to pick it up? Again, now we're talking about sepsis. Now, sepsis means there was an infection that triggered all of this. And then you've got your SOFA scores, and then there's things, are they good or they're bad? That's looking at just organ failure. This is what we've already spoken about. We know that we must know what is organ failure. If the person's blood pressure is dropping, there's some cardiocirculatory failure. Okay, the kidney function is not going, urines are coming out, there's some failure there. Okay, every system we're looking at, we can pick up. They're starting to pick up some failure. Okay, so this is one way of doing it. If you have done the score, it's actually quite straightforward. Once you've done it, you kind of go, I'm just picking numbers together. But it's not doing that. It's asking you things like platelets. And you're like, I just put it in, that's fine, okay. Then it's asking me about some kidney function. Okay, I'll just put it in there. And then it's asking you about liver function. Okay, I'll just put it in there. What is it doing? It's going through the systems, okay? If a liver's doing badly, bilirubin, transaminase, these things are going to go badly. Okay, the liver's failing. Ooh, that's a bad thing, okay? Says you got 10 minutes. I thought 25 minutes are done. Let me know. I was going to stop now. He wants me to keep talking. So you've now got that. Now I go on kidney function. Now when I see a urea going up and a creatinine going up, is that just, oh, it's something else? No, it's a system that is failing. Okay, this body's under strain. If I look at platelets, we're looking at then there's more failure, hemopoietic failure. When your PaO2 and your FiO2, and that sounds all complicated. Hang on, I'm measuring how much this patient is coming in. I'm giving them 40% oxygen. This is how much oxygen I've got in the blood, this PaO2, and I work out this ratio. I go, hang on, okay, that's okay. Now I'm giving them 100% and I'm getting the same figure. What does that mean? Wow, this system is failing. I'm pouring oxygen into this person and they're getting this figure. And we see that happening. Okay, he's getting worse. We may not be able to stop it, but we must recognize it and do the right thing by it. And or maybe we're causing it. Maybe too much volume is doing this. Maybe it's too much. This is the thing that keeps people up at night trying to sort out. Okay, so it's for us to understand and look at a patient that way. Then we'll start to work out what we're doing here. Okay. Then early goal-directed therapies. Now, there's a lot of things as that is picking goals. Now, these are important. We want to be able to go, okay, what is my goal? I want to get to this point. I want this and a blood pressure of this. But pick good goals. That's the key thing. A blood pressure of just 120/80 isn't necessary sometimes. That's not the goal. Okay, now certain protocols are very clear. They say, this is what I want, this is what I want. I want to get improvement. I want to get here. But sometimes we've got to realize our goals have got to be clear. I want the patient to do well. I want the cells to be perfused. I want him to make urine because that means he's getting enough perfusion to his kidneys. I want him to do this because that means he's doing well. Okay, so that's what goal-directed therapy looks like. And trying to support each one while thinking about them is the key. Okay, so finally, let me take you back to that clinical case. So that lady came in, put her on the bed. She was tiny. The paramedics were like, I couldn't get a line up. I should have got a line. I couldn't get fluid in. They put her on. She was tiny. Nothing else I could tell on her. Put her on the thing. I said, okay, let me see what's going on. I took an ultrasound. I put it on her chest, on her heart, and what did I see? So what do I do with this patient? What does this patient need? Not the volume. Okay. So thank goodness they couldn't get the drip in. Okay. That's what it looks like. So we've got to realize that when we're answering this question, that's what we're trying to answer. We need to know what is going to work for this patient and now, and realize any of these things can harm the patient. Taking that trauma patient who comes in now, who's bled out, or that one you can't even tell, that pancreatitis, you don't realize they've lost all this volume because they're not bleeding. I can't see it, or that trauma patient. Let me put some inotrope running. Fine. You can crank that system all you want. That's not where the problem sits. They need volume. They're just not perfusing. They're not getting where it's supposed to be. They've run out of blood. There's no water going in. There's nothing to carry that oxygen that I need carried. So that's the key thing. That's what I want to get at. So we're looking at shock, understanding what shock means. What does shock mean? Tissues aren't getting what they need. Okay. What are the types of? What is causing it? That's what I'm looking for. Okay. How do I support that? Okay. That's what we want. And that's what all of this does. And it changes day by day and day. And then you're heading this way and they go that way. And then it's this way and that way. That's part of it. Okay. So, I don't know where I sit time-wise, but if you guys have any questions, now would be the time.
Thanks very much, Daniel. Appreciate that. Got some questions for you. Just as a supplementary comment, it's really important, as Daniel has gone through, to keep in terms of shock, because you want to know, is it fluid for hypovolemia, and be able to identify and think about which one it is, especially in critical care. And emergency medicine physicians are very well trained in using ultrasound. We're getting ultrasound machines in most of our ICUs. We should be using them similarly to try and identify, like in Daniel's case, why the patient has shock. Dr. Fulton?
I think it's a very important Thanks. I think it's a really important topic, and I think it's not appreciated how important that primary or first assessment. You're the guy that meets the patient first, and I think the simple things we were always taught: history, examination, special investigation. If the patient can give you a history, it's really important, but sometimes you don't have the luxury of that. And yeah, I think it's very valuable that people approach shock patients, and time is of the essence. You don't have the time to sort of pussyfoot around and wait for somebody else to come and do things. You're the guy at the coalface. And I think that, good quality nursing staff in the trauma unit or in the emergency department is critical in that assessment as well. So yeah, I think it's a really, really important topic. You've got 20 minutes sometimes, if not less.
Thank you. Okay, my question is, I want to know is there any formulated tool, like an algorithm or whatsoever, that helps in terms of identifying and treating shock, like initially when they come in to trauma department?
So, yes and no. There are many, and sometimes it's part of the problem, going, what's the way I'm going to do it? So there are certain ones, and I could break it down and, again, come down to your skill level and what you have available. So, again, as we mentioned, ultrasound comes up with emergency medicine. Guys, we love it. There's protocols. This person comes in, undifferentiated shock. There's like a rush protocol. Okay, I'm going to check this, check this, check this, check this, check this. Okay, heart's beating well. Okay, it's not the heart. Okay, is there any pneumo? No. Okay, is there a pericardial effusion? And I go stepwise process. But the key is there are a few, and it comes down to the next step. Once you go on to obviously more got your lines in, then you've seen it. Like other ones exist, like that whole SVVV, looking at those things and deciding, okay, do I go this way or go that way? So a lot of times there are quite a few, but you've got to go with what you have in front of you at that time. And a lot of times, like we said, history is just the one we would love to have, and that's the one we're often missing. So this particular lady that I spoke about now, once history arrived, oh, she's been in heart failure. She was just discharged. She then asked the family, oh no, the family noticed that she weighed this much 5 days ago. She's now weighing 6 kgs more, which means she's got 6 liters of water she's retaining somewhere. That's all there. And that will decide everything for me from that point of view. So if I have no history, I know what I'm going to go with just this general. We've got ones where we go from just I have no idea to if I have a pretty good idea, I know exactly where I'm going to head, to the ones where I go, okay, I know exactly what I'm dealing with. Now let me get on to some proper invasive monitoring and lines, and I'll follow different protocols then. I'll go, okay, cool. Now let me go according to this. But there's a few there.
And last question, what's your feeling about, since shock can be so difficult to manage and it requires very time-sensitive interventions, about having specialist shock management teams in facilities?
So shock teams is what you'd imagine it to be sometimes. We've got to go a bit further than that. A shock team is kind of going, you can get from the most basic kind of idea of like there's someone who is this team watching to see if someone goes badly. Oh, someone's doing badly, they must come in and assess them. Okay, and you've got more general teams. A lot of people talk about like rapid response teams and that. And these are important things that pick up a person starting to go badly. Then you can get onto very specialized shock teams who are coming in, okay, now shock has been decided, we're coming in. You even get into further levels. You get things called like cardiogenic shock teams. Now that's made up of cardiothoracic surgeons, an interventional cardiologist, ICU. They're very specialized. So all of them are fantastic. When you go through it, you go, okay, each of them has a space. There are challenges though, because again, it's a very intensive resource that you need. Who is available to say you can get 4 people together all the time to find someone? So there's challenges that come with it. Absolute challenges that make it really hard to go, hang on, how do I get this much of a resource together to do it? If I can, it works really, really well. You get the right people doing the right thing very quickly. So there are definitely spaces for it. And the key is that getting a team together who understands that that's what they're there to do can definitely have a fantastic outcome. But sometimes it's hard. Sometimes you need more of a general pickup. So the key is being equipped with everyone knowing what they're doing. And then when you have that team, having that team work well together. Even the little bits in between them. Sometimes we worry about how about too many people working together? Isn't that a problem? Does it delay stuff? If it's specialized, it does really well. Actually working together makes it quicker decisions and gets things done a lot quicker. But it's understanding that resource as a tool that might work in some places brilliantly. Other times you just may not have that resource. So it's something we aim for as best we can.